Hey you guys, welcome back for another week of topics and tips. As y'all know, this month we are doing our practice question series. So this is day 4 of the series. On last week, if you missed it, go back and check it out. Tuesday, Wednesday, Thursday, we covered practice questions in the systems of EENT, cardiology, respiratory, and anemia. And this week we're going to hit on endocrine, GI, renal, and the neural system, okay? But as always, you guys, I like to give you my disclaimer before getting to the videos. For those of you who have been following my videos, taking any of my courses, hey y'all. But those of you who are new to me, welcome. I am Dr. Brittany Weinstock. I am a family nurse practitioner, and I'm the founder and CEO of the Nursing Studio. But I like to give the disclaimer to let y'all know that I do these videos to assist nurses and nurse practitioners for success on your exam and your boards, as well as in practice. But I just need y'all to keep understanding that medicine, there's nothing absolute, right? So we go by patient basis. We follow the guidelines, and this is strictly to kind of help you to be successful as you follow that path and journey, and just take it as such. The guidelines change. Some of the tests, they don't move until they're updated to the current guidelines. So I am providing you with the resources for the current testing guidelines. So that's what this is for. Follow me. Let's get into these questions. Question number 1 states the nurse practitioner diagnosed her patient with type 2 diabetes and is planning to prescribe metformin to treat. When reviewing the patient's history, what finding would warrant the need of another potential treatment option? Is it A, hyperlipidemia, B, an shellfish allergy, C, hepatic insufficiency, or D, osteoarthritis? All right, y'all take a moment and tell me what you think in the comments. All right, you guys, I always tell you to read the stem of the question first so that you can ensure that you are answering what they're even asking you, right? So the stem of the question states, when reviewing the patient's history, what finding would warrant the need of another potential treatment option? So it says the nurse practitioner is planning to prescribe metformin, right? Because she just diagnosed her patient with type 2 diabetes. We know metformin is that first line therapy that we typically go by, It's a big one, metformin, aka glucophage. But we also need to be able to look at things that would warrant using something else, right? And so is it A, hyperlipidemia? No, because a lot of times when you think of that, like metabolic syndrome, the triad, there's a various amount of things that people typically have common, that's common together with certain patients. A lot of them may have diabetes and hyperlipidemia and hypertension. And elevated BMIs and things of that nature. So, no, that's not, no, even if you're in doubt, you can kind of probably eliminate that. A shellfish allergy, mm, shellfish allergies do are contraindications with a lot of things, but no, not metformin. Hepatic insufficiency, yep. If metformin doesn't have many contraindications, but hepatic insufficiency is one of them. So when you're looking at that liver function and gauging a few things when you are assessing that the patient has a history of it, or if you notice this, you don't want to initiate that metformin as their treatment option. Okay. All right, question number 2. A 22-year-old female presents to the office today for follow-up. She was seen in the office 6 days ago and was diagnosed and treated for an uncomplicated UTI. She was treated with nitrofurantoin for 5 days. She states today that she continues to experience dysuria, urgency, and now notices an odor after urinating. She is afebrile and continues to deny any flank pain. Based on these findings, what is the next best steps? All right, you guys, take a moment and tell me what you think. Is it A, continue nitrofurantoin for 2 additional days? B, repeat a UA and a Coltrane sensitivity, initiate Cipro 500 BID for 7 days? Or C, repeat a UA and have the patient to return in 1 week? Or D, advise the patient that this is normal and it takes time for the antibiotics to take effect and to follow up in 1 week. All right, take a moment, tell me what you think in the comments. All right, you guys. So, stem of the question states that based on these findings, what are the next best steps, right? So, this patient was there 6 days ago, so a little shy of a week ago, and was diagnosed with an uncomplicated UTI, right? They were treated with nitrofurantoin for 5 days. Yeah, that's first time therapy. That's common. The person is a 22-year-old female, so yeah, they would fall typically in that uncomplicated category unless they had some weird symptoms or were pregnant, right? So they're uncomplicated. They were treated for 5 days on the nitrofurantoin, so that's good. But now, 6 days out, she's completed that nitrofurantoin, or should have, states that she continues to have the dysuria, urgency, and now has malodorous urine, right? And so the patient's afebrile. She doesn't have flank pain still. So you can kind of rule out acute pyelonephritis, but kind of keep that in your mind. But you know how we do when we're creating our differentials. That's starting to kind of fall lower to the list. But when you notice these things, what would you do next? So would you A, continue the nitrofurantoin for additional 2 days? No, not really. Because if you think about it, when you have uncomplicated UTIs, you typically treat from a 3 to 5 day window. And when you have complicated UTIs, you typically treat for 7 to 10 days. And some, depending on the medications, can warrant that 14-day therapy, but that's a little bit typically when you get into that acute pyelonephritis. So the 2 additional days really is not going to give us too much significant treatment, right? B says repeat a UA and a Coltrane sensitivity and initiate ciprofloxacin 500 milligrams BID for 7 days. Now, we've already done that. The UA, the Coltrane sensitivity, they've been on antibiotics. Would you do that again? Um, yeah, that B is actually the next best answer for the next best steps, because what happens is, yes, you will keep that in your mind that that antibiotic can affect the results, but you have already completed a UA prior to this initial treatment, right? So you want to repeat a UA for any changes, do a culture and sensitivity. You still want to consider this, and you're ruling out that acute pyelonephritis, right? As well, they don't have the a fever, they don't have the flank pain. You're going through all of those steps to make sure you don't need to go a different path of treatment, but they have already completed that nitrofurantoin. Let's switch to a different antibiotic drug class and see if that is more effective with them. So switching to that ciprofloxacin would be great, and for 7 days now, because this is more of a complicated case, as they didn't have resolution from the treatment when they were uncomplicated, right? So B, repeat the UA and culture sensitivity, initiate Cipro because we want to go a different route from what we did the first time, and then give them that 7 day window for a complicated therapy treatment duration, right? And then let's just look at the last two and see why those are incorrect. Repeat a UA, yeah, but have them return in 1 week. No, we need to do something now. We don't want to wait another week and allow this to brew and fester and worsen, right? And then D, same thing. It's not a normal finding. So you can scratch those two. All right, question number 3. A patient presents to the office today with complaints of right upper quadrant pain and nausea. The nurse practitioner is considering cholecystitis as a differential diagnosis. As sorry, as she continues her assessment, what is the best test to complete to confirm or rule out her diagnosis? Sorry, y'all. Something was in my eye when I was reading. Let me start over. That was horrible. So, question 3 states a patient presents to the office today with complaints of right upper quadrant pain and nausea. The nurse practitioner is considering cholecystitis as a differential diagnosis. As she continues her assessment, what is the best test to complete to confirm or rule out her diagnosis? All right, you guys. Is it A, McMurray sign, B, Murphy sign, C, Soa sign, or D, Cullen sign? Y'all take a moment and tell me what you think in the comments. All right, all right, all right. Stem of the question states, as she continues her assessment, what is the best step to complete to confirm or rule out her diagnosis, right? So she's thinking cholecystitis. The patient has this right upper quadrant pain, they're having nausea. You're thinking cholecystitis. So what would you do next to confirm if it actually is cholecystitis, or to be able to rule it out and say it's not, right? Would you do McMurray sign? Uh-uh. McMurray science is what? We do that to test for the meniscal tears, right? McMurray's and meniscus. I know it's a bunch of M's, but that's not it. It's a B, Murphy sign. Yes, ma'am. Murphy sign. That's what we conduct when we are assessing for cholecystitis, right? And do y'all know how to do Murphy sign? Y'all should go check out my video. I'll attach it later. But the video when I did the GI and we went all the way through this, I walk you through all of those steps and signs. So go check that out so you can stay on top of that. But I will a real quick sidebar just in case you just need that extra like information while you're studying. Sometimes I just need to see it, think about it, write it down while I'm going through until you have a chance to go back to the video. But Murphy signs, that's when you're telling them to take that deep breath, take it in like a deep breath, and then you palpate that right region, right under that rib cage on the right side, that subcostal region. And if they're wincing, grimacing from pain, that's a positive Murphy sign. Ding, ding, ding for cholecystitis. And then C, psoas sign, and D, Cullen sign. That is not cholecystitis, right? Psoas sign, the obturator, those are for appendicitis, commonly used for those. And then Cullen sign is commonly used for pancreatitis. All right. All right, let's get to our last question for today. So, a patient presents to the office today complaining of excruciating pain to his left eye. He states that the pain is a sudden, intense, stabbing like pain that brings tears to his eyes. He states that he has never experienced this much pain before. Based on these findings, how should the nurse practitioner diagnose and treat? Is it A, tension headache and treat with oxygen and triptans? B, a cluster headache and treat with oxygen and triptans? C, a tension headache, treat with NSAIDs? Or D, a cluster headache, treat with NSAIDs? Y'all take a moment and tell me what you think in the comments. All right, you guys, stemming the question first. Based on these findings, how should the nurse practitioner diagnose and treat? So, okay, the findings are what? So, the patient is coming in, they're complaining of excruciating pain to the left eye. He's stating that it's sudden, it's stabbing like, it's intense, and it's causing him to tear up in pain, excruciating pain that he's never experienced before. So, what do you think about when you think of those things? So, when you're in these situations, not only in tests, I like to tell y'all to like take a moment and see yourself in the exam room with this patient and they're telling you these things. And even when you're taking boards and things, that's how I want you to visualize it because it kind of gives you a better perception. So if somebody's telling you this, start to think of those differentials that instantly come to your mind and how do you work through that? So to me, you're thinking, is it sinuses? Oh, sinuses aren't typically that bad. And he's saying it's the left eye. Okay, so sounding like that's the location, but it's a headache. So just on the left side, it's unilateral. Thinking about unilateral headaches, that can be your migraines and your cluster headaches, right? Because if you think about the tension headaches, those are that band-like headaches. Um, so just thinking through those. So then you can start to eliminate that. So you're thinking, okay, so we're along the lines of cluster. How do you treat a cluster headache, right? And then just kind of marching your way through those steps. So we have tension headaches and cluster headaches here, right? We know it's not a band-like headache, so we can go ahead and eliminate those tension headaches. And I always tell people to like kind of think of tension headaches, in that band-like appearance, because to me, tension, think tension, think stress, So when you're stressed, think at the nape of the neck, like right at the base of your head, or straight across like the forehead region. That band like meaning all the way across. So I think about people being stressed and kind of putting their head across their forehead. I think of that as tension. That's how I don't know, Britney's brilliance. That's how I think of it. It might not make any sense to you, but in my mind, that's where I go. Um, and then the cluster headaches, to me, it's like a cluster of pain, like it just clapped down on you and it's so sharp and intense and horrible, right? So for this, that's that cluster headache that is explaining, and that cluster headache is that intense headache they talk about. It's sudden, it's sharp, um, It's like a piercing pain they describe. People say it's so bad. Like it's common. They tell you to watch older male population because they can have suicidal thoughts because the pain is just that intense. But again, cluster headaches. So you can rule out A and C in this category, right? Now you need to think, how do I treat cluster headaches? In cluster headaches, you prescribe them oxygen as well as triptan. So your answer here is B. Remembering with tension headaches, we don't use oxygen and triptans to treat, we use NSAIDs. So your answer is B. All right, you guys. As always, be sure to like, comment, and subscribe and share with whomever you may think will find this beneficial as well. But you be sure to meet me back here. Tomorrow, we'll be right back here doing questions on these same areas, covering that endocrine, the renal, the GI, and the neural systems, and again on Thursday. And we'll be continuing this all month long so that we're working through all the systems so that you can start to apply and test your knowledge. And I'm walking you through. And if you have any questions, need me to cover any areas, just let me know in the comments and I'm happy to do so. But meet me back here tomorrow, you guys. Bye, y'all.